So just starting this morning with clinical-based module, continuing on with maxillary expansion. A couple of things that should be going through your mind. When do I expand? Do I need to expand? If I expand, what rate of expansion do I use? What appliance would be best for the patient? And everything that I'm teaching you is really based on what is best for the patient. There is no one appliance that you use for every case. And this morning I'm going to sort of run through the common maxillary expansion appliances I use. One thing that I will say in my practice is that all my expansion appliances are fixed in, right? I don't believe in removable appliances. And the reason I don't, I've been in the business long enough to realize kids don't wear removable appliances the way they're supposed to. Most of the removables that you're used to would be acrylic-based appliances. From my lecture yesterday, you'll realize that another reason that I don't use acrylic-based expanders, such as a Shorts plate, is based on tongue posture and based on the fact that the acrylic does affect the remodeling of the palate in a downward direction, which you'll see more when you read the Hans and Enlow textbook, etc. So why else do I expand? If you listen to what I said yesterday, not just for crowding. Obviously, the major one, the evidence-based one, the one that most of your specialist colleagues would agree with you, is when you have no space for the canines. In particular, when those canines may be blocked in the zone that you need to extract the deciduous canine and do some arch development. But I also expand for medical reasons, for improving of nasal breathing. I'm going to talk this morning about the first medical link, which is nocturnal enuresis or bedwetting. And then I'm going to talk about recurrent middle ear problems. But aesthetically, narrow smiles. And one of the big things that we do in the Damon system is to upright that buccal segment, particularly in adults who've had that high palatal vault for many years. And as we said to you yesterday, the characteristic of those patients is what we call a bell-shaped arch form. I'm hoping all of you will start doing Shorts Corkhouse analyses for all your patients so that A, you understand what percentage of them have narrow arches, B, you'll understand that most of the narrowness is in the premolar region, not the molar region, right? See that there is a limit to expansion biologically. And these are the things that we're going to go through. I did touch on my expansion rate yesterday. I better repeat that because that's an important point. I don't do rapid maxillary expansion anymore. And the reason is, in my experience, and I think the literature I showed you yesterday agrees with that, RME tends not to remodel the palate, but simply split it, so you still have two high palatal shelves apart from each other. The remodeling takes up to 6 months. It's by secondary intent, and as a result, stability is compromised. You do get tipping of teeth, you do get periodontal recession, you do get pain for the patient, etc., etc., etc. But if you look at some of the slides we did yesterday and some of the ones I'm going to show you today, slow expansion is actually distraction osteogenesis. And the concept I'm using, and I'd like you to Google search that, is the Lazaroff technique. We're following that exact technique, but we're using it for the maxilla. Now, let's turn our attention to nocturnal enuresis. This happened by accident, I guess, in my practice. I do a lot of expansion, and I was having a number of parents, not just one or two, but maybe 20, 25 a year, telling me, Dr. Mahoney, I don't know whether there's any link, but ever since Johnny has had the expansion of his jaw, he stopped bedwetting. Now, first of all, I didn't know that Johnny was a bedwetter. That's not something that parents are going to disclose at an orthodontic consultation. Yeah. And I said to myself, wow, there must be some correlation here because this is happening too frequently. So I did a literature review. And sure enough, two research papers. Donald Timms, we mentioned him yesterday, and Timms was one of the first specialist orthodontists in your country that believed in expansion. He, early in his career though, was doing rapid expansion. This paper, which was published in Angle Orthodontist, 1990, was a retrospective study, and amazing the sort of results. 1 to 4 months after he did his expansion, the majority of his children had reduced or stopped their bedwetting habit. And his explanation, which I totally agree with, and I'll explain to you why, was that the oxygen saturation, in other words, the improved nasal breathing, and remember, Timms actually measured with rhinometry the nasal airflow, certainly increased the production of a hormone, which is important to control the bladder, anti-diuretic hormone production. So what I did my own study, but we did a proper protocol. So I sent an email to the local hospitals in my area. We published the protocol in Science magazine, and we were inundated with thousands of requests of patients. I didn't realize how big a problem this was. Now, our protocol, we didn't want people to say, oh, well, the kid was going to stop bedwetting anyway. They were a young kid. So I only accepted patients 12 years and older, because bedwetting in a 7, 8-year-old may be spasmodic and may go away on its own. What shocked me is that the medical fraternity had really no solution for bedwetting, absolutely zero. There was drug-induced therapy, there was bedwetting alarms, but nothing really had success. So I selected patients who were 12 years or older because these were the patients who weren't really going to grow out of their bedwetting problem. I was amazed at the number of high palates I saw when these patients came in. Such to the fact that when I go through paperwork, you'll see that in the medical history I'd like you to use for your orthodontic patients, there's certain questions that I ask different to a general dental medical history form. I ask questions like, you know, does your child have nickel allergy? Does your child snore at night? You know, does he have a history of medical ear problems? Is there a history of bedwetting, etc. And some parents say to me, you know what, these are really weird questions, but obviously I explain to them why I'm asking those. But getting back to the study, to make it valid, we used expanders, but the parent, did not know whether their child had an expander that was working or was not working. Does that make sense, right? So 2 cohorts, all bedwetters, all over the age of 12, all had expanders. Parents were turning them, but some expanders were actually designed so that when they were turning, nothing was really happening. Yeah? And no parent knew which had the expander, which didn't have them. That was part of the protocol. And we, in the cohort sample, had the proper expander, had 9 out of 10 kids dry within 2 months of expansion. Kind of amazing, right? And you can read on that online if you just punch up nocturnal enuresis bedwetting with my name, you'll see all that. So why am I sending you this? I mean, this is not a lecture or this is not a seminar specifically on treating bedwetters. But I just want you to understand that when you expand, when you do orthopedics, there's a whole medical interface that you're dealing with. It's not just dentistry. Yes, we do it for wider smiles. Yes, we do it to resolve crowding, but you'll understand more what happens with changes of airflow, what happens with changes of the palate. I'm going to talk to you after this lecture about breathing and the importance of nasal breathing, and how when you breathe through your nose, a couple of things happen. Number one, your tongue hits the palate where it should. But number two, the air you're breathing is humidified, filtered, and regulated in volume. And this is so important for growth of the nasomaxillary complex. So getting back to Tim's study, his expansion was really moderate. You know, I'd hardly call 3 to 5 millimeters a much. It's what we achieve nowadays, even in passive self-ligation brackets. But look at the improvement in nasal airflow. On average, 33%, some cases up to 60%. Obviously, younger children showed greater improvement. We're going to talk to you about when is the best time to expand today, related to the cervical vertebrae. And in his study, 7 out of 10 children had an improvement. 4 became completely dry within a month. So, you know, this is something we're seeing again and again. We talked yesterday about Yuri Kurol and his fantastic research in conjunction with Erickson on the impacted canine, on his own with impacted premolars and late resorption of deciduous molar roots. He also, when he was in the hospital department in Jönköping in Sweden, did study on expansion and its effect on bedwetting. And what did he find? Well, he found that bedwetting was a common symptom amongst children, and those children who had breathing problems. So what sort of child am I talking about? The classic sort of adenoid face, you know, venous pooling under the eyes, cracked, dried lips, gingival hyperplasia, that sort of dumb look posture like this, right? You can see these kids when they walk in for the consult. You don't even have to look in their mouth to know they're going to have a high palate. And his explanation was also related to saturation of the blood. One thing I'm going to run through with you is a little bit of physiology on how oxygen is released to vital organs, right? And it may be revision, but for some of you it may be totally new, but I want you to understand that oxygen is tightly bound with hemoglobin, right, as it's carried around the body. What releases it is the level of CO2. And mouth breathers flush out the CO2 in their lung, right? So I'm going to explain to you how, in my practice, we use a machine called a capnometer, pretty reasonable expense. A capnometer actually measures the volume of nasal breathing. So when I start a child on expansion, when I start a child on myofunctional therapy, when one of my little kids says, or the parent says to me, Dr. Mahoney, you know, we tried that trainer, and every morning when I check on Johnny, I notice that he's spat it out of his mouth and it's his bed. And what do I say? Well, Mrs. Jones, that tells me your child really needs that trainer because he's mouth breathing all night long. And to make sure that we're getting a positive effect, of course, we have baseline data. So in my myofunctional phase 1, the children may not have aggressive records such as radiographs, but they certainly get a rhinometric evaluation using a capnometer. Well evidenced, well research based, etc., etc. Because what we're interested in is the nasal airflow. So let's look at this little chap, and then I will talk to you about expanders. This was one of the first kids that I treated using expansion after I graduated. And the expander is very primitive. It's an expander that I don't use now. Why? It's removable. B, it's got acrylic in the palate. 3, I had no idea what I was doing. I was a sort of general dentist, and the lab technician told me, well, just put a screw in the middle of the expander and just keep turning it. You know, sound familiar? Anyway, this case turned out well. Now, history of this kid. Nice kid, second opinion against extraction of teeth. The whole reason I got into orthodontics, and maybe it's similar for you, I was very disappointed with the quality of the results that are coming back from my specialist orthodontist, you know. And I remember, you know, to this day, the guy that I used to refer all my cases to, I thought was terribly nice, you know, because he would always invite me to these lavish Christmas parties and blah, blah, blah. And of course, how could I compare? I knew nothing about orthodontics, yeah, other than what an orthodontist was. And the moment I said to him, look, I'm interested in doing some of my own work, you should have seen the door. It was like talk to the hand. It was like a big lecture, like, you know, there's no way you're qualified to do any orthodontics. And when I talked to him about expansion and the fact that I was interested in doing a Skip Truitt lecture, oh my God, you should have seen the face change, yeah? But I'm glad I did that and I persevered with that. So please understand that what you're doing is far better quality treatment than what some traditional trained people are doing. Please understand and believe that. I'm traditionally trained, I'm a specialist, but I would never go back to the dark ages. Yeah? Now, this little kid, second opinion against extractions. If we think back to our talk yesterday, in-standing maxillary laterals, right, will influence the position of the canine because it follows the root of the canine based on the research by Brin, B-R-I-N. But look at that guy's palate, right? Can you understand that tongue is not really living there? Just do this for me, real simple. I want everyone to breathe through their nose with their lips together. Tell me where you feel your tongue goes. Where does it go? The tip of the tongue hits the palatine rugae, yeah? Now, pretend you're a mouth breather. For some of you, not that hard. Yeah? Where's your tongue? You understand? Common sense. But at your age, your tongue on your palate's not really going to in any way expand your upper jaw, correct? However, it may help you with snoring sleep apnea. Yeah, you understand that? So even though I have an adult that's a mouth breather, am I going to say, well, big deal? No, I'm going to do some expansion of his jaw. We'll talk about adult expansion later today. But at the same time, yes, I am going to try and improve his nasal breathing because I want him to get better sleep. Yeah? As part of our module on class 2, we talk about the physiology of sleep. We talk about rapid eye movement. We talk about stage 1. We talk about what happens in the different stages. Bottom line is this. Who here has had a really bad head cold and slept with their mouth open all night because of that? Yeah? How do you feel when you wake up in the morning? Refreshed or like shit? Yeah? How many people here have woken up with a hangover? It's the same feeling. It's dehydration. Do you understand? And I'm going to share a few tips with you, and this might sound silly, but you can put some tape on your lips. Right? It's amazing, and we can show you from the research when we do overnight sleep studies, and nowadays we use at-home appliances. And I'll go through all of this in the class 2 module. So in my practice, in my adults, in my children, if I suspect poor sleep cycle, sleep disordered breathing, we actually give them a take-home sleep kit. They sleep in their own bed, and it's amazing the things. Now, the latest thing we're using, and it might sound sort of out there, but it's a thing. The guy who developed CPAP, you understand what CPAP is? It's basically like a vacuum cleaner in reverse. Yeah, it pumps air through your nose, which keeps all the tissues from collapsing. Horrible device, and really you'll learn from me, the majority of your CPAP patients have poor compliance. And we can help them with oral appliances. But the guy who developed CPAP, Professor Colin Sullivan, respiratory physician in Sydney, Australia, he has developed recently, like in the last 2 years, a mat which has no wires on it, etc. Patient just sleeps on this mat, and then in the morning you pull out like a little memory stick, and it gives you all their sleep cycle, their sleep apnea. It's amazing, right? So these are the sort of things I'm going to expose you to, but important things. Young kid, good sleep cycle, extremely important for growth and development. Extremely important for that child's behavior. What do I mean by that? All Western countries, there seems to be an increase in attention deficit disorder. Why? Well, I'll tell you my theory, and I can show you evidence to support this. Many children now have sleep disordered breathing due to high palates, due to adenoids, tonsils, due to allergies, due to whatever. Yeah? If you have young children or have had young children, you'll understand that they behave differently to adults when it comes to lack of sleep. We as adults, if we have a hard day, we just can't wait to put our head down and go to bed. With children, if they stay 1 to 2 hours longer than their normal sleep, what happens? Do they become lethargic or they start climbing the wall? You understand? There's your attention deficit disorder. A child who doesn't sleep well at night, is not going to concentrate well during the day at school. And you know what's driving the use of drugs for attention deficit disorder? It's school teachers, because they don't want to deal with the kid. Trust me. Yeah. So I'm going to show you again lots of research that links bruxism in children to sleep disordered breathing, that links attention deficit disorder, etc., etc., etc. That's for children. For adults, poor sleep cycle can be a lot more serious. We're talking about high blood pressure. We're talking about sleep apnea. But if you change their method of breathing, you're not in any way going to influence their facial growth and development, right? The horse has already bolted. So we're going to go through these concepts with you. But getting back to my friend, that should be a warning, early warning to you. If you look at the base of his palate, you'll normally see purple, right? Like a bruise. Why? Because just like you see purple here, it's poor oxygen saturation, poor oxygen exchange at night. Lower arch, not too bad. The crowding is really a compensation when you are a mouth breather. And Dr. Helsing in Karolinska Institute, Stockholm, showed this. When you're a mouth breather, your mandible drops back, and that increases the lower lip tension. So mouth breathers, high angle class 2s, tend to have a lot more lower incisor crowding, related to what the lip is doing. So what did I realize about this kid? If I put a mirror under his nose, it never fogged up. This kid was a perennial mouth breather. So we got an ear, nose and throat evaluation. Yeah. And a lot of the literature I'm giving you comes from ear, nose and throat journals. Your goal in your bucket list is to contact ear, nose and throat doctors in your country, try and set up a symbiotic relationship. In my practice, number 1 source of referral, word of mouth. Number 2 source of referral, ear, nose and throat doctor. Number 3 source of referral, dentist, but dentist that I've educated. So the literature I'm going to give you, I want you to find in your area, whether you're in Poland or Northern Ireland or Scotland, you find ear, nose and throat doctors that can work with you. And I will give you, not in this module, but in the mixed dentition module, all the literature references in what we call an airway pack. And those references I want you to read, and I want you to send to your ear, nose and throat doctor and says, doctor, these are articles linking what I can do to what you do and how we can work together. Could you please read them, and could we just find time to meet for lunch, etc., etc. You'd be amazed how many referrals you get from that ear, nose and throat doctor. How many high palates do you think an ear, nose and throat doctor sees every day? But he has no idea that it's a high palate. You understand that? Ear, nose and throat doctors, even though they're top specialists in the medical field, they don't know what a class 2 malocclusion is. They don't know what an open bite is. They don't know what a cross bite is. But if you teach them, you'd be amazed how willing they are to learn, right? And if you show them research like you can improve nasal breathing by 60%, they're all ears. Why? Because they want their kids to improve as well. They don't want to do a TNA operation to find the kid is still a mouth breather. Getting back to this expander, poor design. Why? Because if you do your Schwartz-Korkhaus analysis, you realize that you need to use 2 screws. One in the premolar region, one in the molar region, or just 1 screw with a fan gear at the back because you don't want molar expansion. I'll go through that. Anyway, I put 2 T-springs here for the laterals, so that as we expanded, we kicked them forward. We had occlusal coverage to open the bite. Any idiot can do this. Do you understand? This is the simplest type of orthodontics. This kid was a good kid. He wore his appliance well. However, the rate of expansion back then was a little bit too high because I was doing back then much more rapid expansion. And you can kind of see, that's not a good look. But at any rate, he wore his appliance really, really well, highly motivated kid. After we'd reached the right amount of expansion, how did I know that? I guesstimated. I looked at the lower, I thought, well, if I expand any more, it's going to go into a reverse crossbite, so I guess we better stop. Nowadays, of course, I've planned that. Remember, short scorecards, I've planned that. And then we just waited for his canines to drop in. Yeah? And can everyone see how this kid's breathing through his nose? Now, back then, I didn't understand anything about maxillary position. Yep. I understood a little bit about size and that the kid had no room for his canines. But if you look at this kid's face, can everyone see he is maxillary deficient? So, in this day and age, and this is where I want you to be, you take your lateral ceph, you do your tracing, you do your anterior arc, and you realize maxilla is behind anterior arc. And at that kid's age, what would you now use? What would I now use? I use a bonded Hyrax fixed in with pads for a face mask. And then not only would we have improved his breathing, made room for his canines, we would have improved his facial aesthetics. Does that make sense to people? Right? So I'm just telling you from, where I started to where I am now. I better turn that off. We absolutely are doing far better quality treatment. Now there he is without any fixed braces, 5 years after therapy. And is that a good result? I mean, this is what motivated me to really get into orthodontics, because I wasn't seeing as good results as that after the kid had come back after 3 years in braces. You understand? Right? Now, does he need braces? Does he need phase 3? Absolutely. And that lateral clearly needs some torque. Look at the arch form. Do you think the tongue is happier? Yeah? Now, I did that without really knowing what the hell I was doing. But the point I'm saying to you is if you do know what you're doing and you diagnose properly, you get predictable results like that all the time. Why do the lower incisors fix themselves? Related to tongue posture, and we'll go through this. When a kid has an open bite, is a mouth breather, to stop saliva coming out of the mouth, the tip of the tongue forms a seal with the lower lip. Does that make sense? It's called a tongue to lower lip swallowing posture. What do you think happens to mentalis? It becomes hyperactive. The hyperactive mentalis has a negative effect on the teeth because it's putting pressure. Yep. Think back, and one reference I'd like you to get and read, British Journal of Orthodontics, 1980, British Journal of Orthodontics. You can walk straight upstairs here to that room that you walk past every day, but I've never seen any of you in there. I'm not talking about the museum, right? The library. British Journal of Orthodontics, 1980. The first paper that Rolf Frankel had published in English. Name of the paper, The Functional Regulatory Mechanism. When I talk about FR2, FR3, FR doesn't stand for Frankel. It stands for Functional Regulation, which was his philosophy. Now, if you read that paper, British Journal of Orthodontics, 1980, Rolf Frankel, The Functional Regulatory Mechanism, it will explain this perfectly. I was born again when I visited Frankel's practice and realized he wasn't using fixed braces. He wasn't using expanders, but he was treating at the right age. And he was using the tongue as his expander. And his stability is far better than any stability that I see with my fixed appliance cases, right? So this kid, just using as an example what can be achieved even with a poor understanding of what's going on. But you get in early, you influence facial growth and development, you change tongue posture, you improve nasal breathing, and really the teeth are going to erupt in a zone of equilibrium. The book I recommended yesterday, Prophet, he has an equilibrium theory in that book. And basically he talks about the teeth erupting in a zone between the tongue and the lower lip and in the upper between the tongue and the buccinator. Yep. And that's exactly straight from Frankel. So before we now launch into appliances, which ones we use, how we activate them, etc., etc., I want to talk just a little bit about nasal breathing physiologically. This technique was developed again by another Russian, but their scientific training is very, very good. In some of the Eastern Bloc countries, before you do dentistry, you have to do medicine. Poland was like that for many years. And as a result, it makes the dentist much more like an oral physician, thinking about medical implications of what they do. So let me introduce to you what's called the Buteyko breathing technique. Now, Buteyko, like the word expansion, has a bad reputation because when it first came on the market, nothing to do with the guy who developed it, but people who were recommending it for asthmatic children as a method of them not needing to use nasal corticosteroids. Yeah? So you can imagine, your country, like my country, like most Western countries, is 100% driven by drug companies, right? And just like the companies that make antiviral software for your computer, do you think they're the companies that develop most of the viruses that released? No, of course not. That would be unethical. Most children who have a hyperventilation episode are deemed to have an asthma attack, right? And again, if you start looking at your medical histories, who would agree here in the last 20 years, there seems to be a lot more children with asthma, right? That's a bit like a lot more children with ADHD. But if you go to a medical doctor in any Western country and you look on their desk, is there anything that they have bought themselves with their own money? Their pen has a name for drug company on it, and it's probably a Mont Blanc pen. Yeah? Their computer, it's all related to how quickly they can write a prescription. That's unfortunate. That's Western medicine. What they came up with and what he came up with is a method of treating asthma without using medication, and it's hugely successful. But of course, because it was in the face of a lot of the powers that be, who were asthma specialists, respiratory physicians, of course it was met with a great disdain. So I don't use the term Buteyko, just like I don't use the term expansion. I use the term arch development. I use the term breathing well technique, right? Now, you can find all around the world, I assume even in the UK, Buteyko trained practitioners. There's a really good guy in Ireland, Patrick McEwen or McCowan. Have you heard of him? Yeah. Who's Irish here? No, I know. You know? Yeah. He's one of the best in the world. Yeah. He's videos and stuff. Right. So if you ask him who he knows, I'm sure he'll put you in the right direction. But again, just like you need a good ear, nose and throat doctor, just like you need a good speech pathologist, you need someone to help your kids to change their breathing. Why am I saying this? We think that if we expand the jaw, the kid who's been a mouth breather for 9 years will become a nasal breather. We think if the kid gets large tonsils removed, the next day he's going to breathe through his nose, right? Who agrees or disagrees with that? Just like we learn how to walk, we learn how to talk, we learn how to breathe through our nose. But it's not something that comes naturally. When you're born, and if you ever go to a nursery, like in a hospital, look at all the newborns. They're all nasal breathers. You see their little chests sleep up and come out. Who heard the saying, he sleeps like a baby? There's a lot to be said with that, because babies, when they're born, actually are obligate nasal breathers. Yeah? They have to be for breastfeeding, blah, blah, blah. But something happens, more in the Western world, that these kids convert to mouth breathing. Now, there's lots of theories on that. My theory is related to the fact that they're not breastfed long enough. Another theory is in the Western world, we're terribly scared about getting different diseases, so we vaccinate our kids to the eyeball. Yeah? What is a vaccination? Basically, the immune system goes into hyperdrive. What is the body's primary response to that? Enlargement of adenoids and tonsils. Does that kind of make sense? What happened years ago? The way you got your immune system developed, your parents would allow you to eat mud, right? Nowadays, I've seen it on the streets of London, if a kid drops their pacifier, the mum's there with the alcohol wipe and the, right? So, what Buteyko was a Russian respiratory physician, and he realized that kids who had asthma were effectively over-breathing. Now, over-breathing does what? It flushes out the CO2. And we're going to learn a little bit of physiology because it will help you to understand what this is all about. Yeah? And yes, I do recommend, if Patrick McEwen has some DVDs on this technique, watch them. And you could, in theory, train one of your own staff to do this thing. In my practice, we have clinical coordinators who have done the course and know how to use the capnometer. So what is the capnometer? It's a quantitative way of measuring whether this thing is working. Parents don't want to fork out money with some sort of mystic technique. Do you understand? Right? If someone is hyperventilating, yeah, what do you normally do as a first aid measure? Brown paper bag. And what is that doing? It's increasing their CO2. Do you understand? So you kind of know this stuff, but I want to explain to you why. Now, everyone talks about, oxygen as being the important substance. And yes, it is important, but it's only as useful as the amount of CO2 that we store in the body. And the unfortunate thing is we can't store oxygen. Yeah? So the air we breathe is about 23% oxygen and very, very low quantity of CO2. And everyone thinks, well, CO2 is a bad thing, oxygen is a good thing, because that's the way we're sort of led to believe, particularly, when we're talking about using happy gas, nitrous oxide, flushing with oxygen, when we talk about hyperbaric medicine, etc., etc., etc. Yep. But if someone was to collapse today and you had to give them mouth to mouth, really what you're breathing into them is a large amount of CO2. Remember, CO2 has many uses, but oxygen only has one, and that is the release of energy. So because we don't have to store oxygen, it to us is important, but not as important in the regulation of our breathing. What is more important is CO2. And where does CO2 come from? Number one, when you eat, byproduct of your metabolism is going to be production of CO2. When you exercise, yeah? And that CO2 needs to be stored in the body. Where is it stored? Primarily in the lungs. What is the purpose of CO2 from a physiological perspective? It does three important things. And when I talk to you about spasm of smooth muscle, a lot of that is to do with the bedwetting we were talking about. The bladder is effectively smooth muscle. But first thing, it triggers a breathing reflex. In other words, the amount of CO2 in our lung actually influences our method of nasal breathing. Mouth breathers tend to have a lower percentage of CO2. If we can increase that CO2, we can help these patients change their breathing posture. Why is that important to me as an orthodontist? Well, if it's a young kid and I can change them to breathe through their nose, effectively their tongue becomes the expander. If it's a middle-age type kid, a young teenager, late mixed dentition type kid, then the stability of my expansion is based on the tongue hitting the palate, right? If it's an adult, it may help their snoring sleep apnea. And the last thing we're talking about here, and I mentioned this earlier this morning, is the oxygen we need, which can't be stored, can only be released if there's the right amount of CO2. So let's talk about the first thing, the breathing reflex. In the medulla, you have a gauge or a trigger, very much like the temperature gauge in a room that controls the temperature. And basically it reacts to the pressure of CO2, which should be about 40 milligrams mercury, or roughly 6.5%. And if it is set at that, then that results in normal breathing. So in our practice, we measure that as a baseline. We measure the amount of nasal breathing with the capnometer, and then after our therapy, whatever that therapy is, whether it's an expander, whether it's just breathing, whether it's a myofunctional trainer, we go back and we take new measurements so we can show the parents if there's been an improvement. So what is normal breathing, right? If you ever do a Buteyko course, and I'd recommend you do one, the first thing they'll get you to do is to go on a capnometer and then just breathe. And you'd be amazed how many of you are used to over-breathing. 4 to 6 litres of air per minute, which is equivalent to 8 to 12 breaths per minute. If I was to put all of you on a capnometer today, right now, I guarantee you most of you will be breathing between 30 and 35, right? Top athletes use this technique. If you watch professional runners, they don't run with their mouth open. If you go for a jog, how long does it take you to start mouth breathing? So what we're trying to do here, we're trying to reset the thermostat in the medulla to be the right response for the volume and for the number of breaths per minute. So we want that CO2, which drops very low, to go back to 6.5%. Now if we do that, then we can reset and we can make it easier for the kids to breathe. Constant exposure to CO2 levels that drop below 40 millimeters mercury, below 6.5%, then what happens is the person has to start over breathing. What a nose is made for, right? And yes, there's the olfactory side of things, but mainly it's for breathing. Why does God give us nasal hair? It's not to make us more facially attractive. Yeah? The cilia filters out all the bugs. If a little kid's a mouth breather, and I will talk later today about what I'd like you to do at an initial consult when you suspect the kid's a mouth breather. I'll give you my airway chart, and I say to my parents, right, I want you to go home, and over the next 2 weeks, I want you to go in 2 or 3 times a night when your kid's asleep, and I want you to see if their mouth's open or closed. I want you to take a photo of that, or I want you to take a video of that, and I want you to fill out this chart. And you'd be amazed how the parents come back and say, geez, Dr. Mahoney, I'm amazed that you picked up my kid was a mouth breather, because you're absolutely right. Here's the chart. Every night, mouth open. 70% of the time snoring. Then the parent is motivated to go and see the ear, nose and throat doctor. Does that kind of make sense, right? So I'm going to explain to you the stages of how now this is all under phase 1. Is it important? It's absolutely important. Because if you don't do this, if you don't establish normal nasal breathing, if you don't establish normal tongue posture, your orthodontics is a total waste of time. Your relapse of your teeth is going to be 100%. your relapse of your expansion is going to be 100%, right? So we really need to understand what's involved here. When we breathe through our nose, the air we breathe is filtered, it's sterilized, it's controlled in volume and temperature and humidity if you breathe through your nose. If you mouth breathe, then all that air coming through, going straight through to the lung, it's unfiltered, it's germ-laden, and this is really what causes half these kids to have these huge adenoids and tonsils, right? So we want to try and change this posture. As I said to you, CO2 is stored in the lung. If your mouth is constantly open, the CO2 levels remain consistently low. And this medullary trigger resets itself to overbreathing to compensate. So what causes the mouth breathing? Lots of things. We see, of course, kids with allergies. There could be habits. In our situation, we're seeing kids who've developed the poor oral posture right from day one, from when they are put on a bottle to feed or when they're using a pacifier. Mouth breathing causes a number of problems. One of the things it does, and these are the sort of kids that I want you to look out for, right? So if you look at this girl, does she look healthy? Right? Now, she's 5. So remember I said to you yesterday, for a 5-year-old, I don't take full orthodontic records. Why? Cranial base is not fully formed, then they don't have any baseline, and I do agree if people come down on you hard for taking full radiographic records at that age. I think it's a little bit silly. Yeah? But does she need treatment? Do you wait till 7? Do you think her palate's going to develop naturally? She is a mouth breather. She's got a tongue thrust. She's got venous pooling under her eyes. She, short of wearing a t-shirt, help me, is a classical kid for early treatment. What do I do with this kid? Tomorrow we're going to talk about trainers, myofunctional trainers. But myofunctional trainers only work if the kid can breathe through the nose. A myofunctional trainer, do you know what I'm talking about, a little trainer? Is only successful if the lips are together at night. The lips together at night can only work if the child can breathe through the nose. So all of this is linked. So when you see a child who is a mouth breather and has a high palatal vault, like the last kid I showed you, if you can get in early and change their breathing and their tongue posture, you can do some powerful things. Now, let's talk about smooth muscle. Smooth muscle is found throughout the body, in the respiratory system, digestive system, basically all hollow organs, all right? And that's why this technique was initially developed for asthma, because what happens in asthma, you're talking about the bronchioli being affected. So what happens when smooth muscle goes into spasm, just like an asthma attack, you're going to get problems with breathing. When smooth muscle goes into spasm from the perspective of bedwetting, we have a similar sort of concern, because the bladder that's partially filled doesn't activate the stress sensors. So, you know, I ask adults that come to see me, and remember, about 15% of my practice is sleep disordered breathing, right? We do a lot of snoring sleep apnea. We fit CPAPs in our office. We also do a lot of oral appliances, and we're going to cover all of that as part of this course. But one of the questions I ask, you know, Mr. Jones, how many times a night do you get up and go to the toilet? Now, if he says, look, 2 to 3 times a night, do you think that's normal? Right? Absolutely not. And I explain to him what's involved there, and sure enough, you find that that guy is a mouth breather. And is that going to affect his facial growth and development? No. Is it going to affect his quality of sleep? Yes. Yeah. I really got into snoring sleep apnea because of my dad and my uncle, right? Two brothers. My dad had terrible snoring, such that my mum would sleep in another room. He had all the signs, but I knew nothing about it, yeah, until he had a stroke. Then I got all interested in knowing what's going on. He had to use CPAP, but of course my mum said it was worse than the snoring. It was like sleeping next to Darth Vader. Yeah. My uncle was quite a famous detective, not as famous as Sherlock Holmes. Did Sherlock Holmes really exist? Yeah. My uncle was a murder detective. Yeah. So of course you can imagine he gets calls all time of the night when there's a perpetrator and he has to go down. So he had severe sleep apnea as well. And he didn't realise it, but he used to fall asleep during interviews of criminals. Can you imagine that? And what forced him to do something was one night he was driving back from one of these interviews in a police car, and he came to a set of traffic lights, and of course he just dozed off. Now, being a police car, everyone just drove quietly around that car. Right? This was like, I think at 2 in the morning. He woke up at 8 in the morning, still at the traffic lights. Yeah? And I think he realised he had a problem. And you'd be amazed if you look at the statistics. I can quote you US and Australian statistics, I'm not sure about UK, but 1 in 4 adult males past the age of 40 has obstructive sleep apnea. Yeah? And snoring in an adult may not be related to cessation of breathing. Snoring in a child is absolutely needs to be fixed, and we'll go through the differences in this. Right? So getting back to these constant trips to the toilet, this CO2 or lack of CO2 is causing the spasm of smooth muscle. If we can improve CO2 in the lung, we're going to trigger proper breathing, we're going to prevent that spasm, and this is where it all helps medically. Third thing is oxygen. I want you to kind of imagine that, oxygen is transported around the body in the bloodstream, almost like a freight train carrying goods. But when the train comes to the station, nothing is actually offloaded or released if the CO2 level is not correct. Does that make sense? Because the oxygen is bound to hemoglobin and can only be released with the right amount of CO2, which is related to the pH. So if the pH is too alkaline, the oxygen forms a very tight bond and it will not release. If you can change the pH, and it's very, very important to get that pH to be at the correct level based on the CO2, then you are going to get the release of oxygen. So they're the three things that I see from a medical model when we do expansion and when we encourage nasal breathing. So if I have an adult that has a deviated nasal septum, large inferior turbinates, obviously I need an ear, nose and throat doctor to help me with that. I can't just give them a snoring appliance. Yeah? Many children who have really bad eczema, what you've got to understand is that the skin is one of those organs, but unfortunately it's the organ that's furthest away when it comes to blood supply. So as a result, you can imagine it's the last one to get whatever oxygen is available. And I find with my patients, and parents report this to me as well, we're talking about teenagers who come into me at 12, classic mouth breathers, they snore at night, they're lethargic to wake up in the morning. We do expansion if they're upper jaw, we do orthodontics. And parents make comments like, kid's acne has really, really improved. And the only thing we can think of that's different is your orthodontics. Yeah? And again, if one person says that every 20 years, you're going to think, oh, you know, not related. But when a lot of people start saying that, then you start looking at really what's going on here. So, fixing the problem. We want to reverse the mouth breathing. We want to send messages of increased CO2 to this medullary center. And it is possible to reset that trigger, and it is possible to return to normal nasal breathing. But to do that, we need to have a little bit of understanding of what goes on. Has anyone seen the book by David Page, Your Jaws, Your Life? Yeah? Who has read that book? Right? Now, you have. How many of you give that to your parents?
It's very expensive. It's about £15.
You know, you may be sort of hopefully motivated during these 3 years to understand what you're doing as an oral physician, but you need to educate the parents, right? That book is fantastic. A, it has great references in it. B, it talks about all the things that I'm talking about. Bedwetting, middle ear problems, bruxism, snoring sleep apnea in children. It's very, very good. Right? And there's another book I'm going to recommend, which you probably wouldn't want to give to all your patients. It's written by an orthodontist who's a friend of mine in the US. His name is Dr. Kent Lawson, Lauson, right? New book, released literally last Christmas. And it talks about orthopedics and orthodontics as opposed to taking teeth out. He asked me to write the forward chapter because, and it's simply called, the book is called Straight Talk About Crooked Teeth. It's designed for parents. He's been on Oprah, and it's just like the sales have just gone off the roof. Yeah. So again, please don't waste money. If you contact me, obviously I'm not making money on this deal, but I'm very passionate about you guys doing the right thing. To me, what makes me happy at night is not if I've earned like $1 million versus 900,000 for the day, but whether one kid in the world somewhere has had better quality life, you know, etc., because of my teachings. Does that kind of make sense to you? Really, I'm passionate about that. And this book by Dr. Lawson, really, you can imagine it got a lot of orthodontists offside because he says things like, you know, taking teeth out is ridiculous based on blah, blah, blah. And he shows lots of case histories of second opinions. It's really well written. Yeah? And I give that to all the patients who come to me for second opinions against teeth out, blah, blah, blah. Okay, now let's talk about how we use expanders. Let's talk first of all about treatment timing, right? So I don't want to see any of you over the next 3 years recommending a rapid expansion for a 30-year-old, right? What we want to do is understand research. I want to explain something to you. I have like 3 caps. One, of course, is a clinician. Hugely successful, busy practice. Love doing what I do. Would go to work even if I didn't get paid. Yeah. Second hat is as a researcher. You know, I have students that do certain projects under my supervision, and so I need to be well aware of research protocol, etc. Third cap is as a lecturer. So as a lecturer, I can't be any good if I'm not a clinician. Does that make sense? The worst lecturers are those who didn't treat a patient for 10 years. Who would agree with that? Second thing is, I read the research. People say, how the hell do you cope with long flights? You know, I find that many times I run out of time on a 15-hour flight, yeah? Because I read all the literature, all the journals. So what I'd like you to understand, I'm like the equivalent of your Reader's Digest. I'm giving you the summaries, yeah? But I want you to have in your folders a whole list of these references, and you'll need to refer back to them many times, right? And that's where I'm happy to get emails from you. You know, someone's having a go at me for blah, blah, blah. You know, can you give me any literature support the expansion rate you were talking about? Bang, straight away I'll fire you the references, yeah? Now, this was a great paper. Of course, we talked about Barchetti yesterday. Another famous name, Jim McNamara. Jim McNamara, why is he famous? Probably the most publications in referred orthodontic journals than any other researcher. What influences Jim McNamara? Why is he a good guy? When he went to orthodontic school, the girl who was in his class was Rolf Frankel's daughter. You know what I'm saying? Yeah, he was taught extraction-based orthodontics. Christine Frankel said, "Oh, come over and meet my dad and see what he's doing." All of a sudden, he changed his ways. Do you understand? So it's kind of interesting that there's some sort of influence in this regard. Now, what did the research paper do? This paper looked at expansion in two groups of subjects based on their age, but not just their age, but their cervical vertebrae, right? And he looked at the amount of expansion that was possible, but also the stability long term. Published in a highly respected journal, Angle Orthodontist, 2001. And what the research showed is that the expansion before the peak skeletal growth velocity, in other words, before you got to CVM3, was the most stable and was the most efficient. So what that's telling us is that if I have a kid that you present to me who's class 2, but CVM2, I'm not going to be too worried about his class 2 because I know his mandible doesn't even start growing until CVM3. But if he's got a high palate, crossbite, narrow maxilla, I do want to do expansion at that age. Yeah? So all the stuff that I do clinically is based on my understanding of facial growth and development. Hans and Enlow will be a tough book for you to read. So if you don't want to read that, I've asked Jane to send you a link which is free of charge that has a summary of all his chapters, yeah, on the internet. So if nothing else, at least read the summary. The problem with the summary, it doesn't have all the diagrams, yeah? But has anyone read Hans and Enlow, Essentials of Facial Growth? Right. Who recommended that to you to read? I did. Right. So one person actually took my advice. It's amazing. It is difficult to read, correct? Right? But it's excellent in understanding what goes on. Now, this comes from his book, and he talks about how the palate grows. Now, if you understand how the palate grows, it's what he calls the protruding muzzle effect. You realize that at one side it's resorptive, and on the other side it's bone being deposited. So bone is being added on the inside of the arch, and that is what increases the width and makes the palate become wider. So it's exactly what Melvin Moss was saying, right? Form follows function. So if you bind up the palate, you're actually not encouraging normal growth and development. Bottom line. So if you take my advice, do not use expanders that fully cover the palate with acrylic. I can show you as a researcher, as a clinician, that that is not the way to go. I'm not saying it doesn't work, but if you look at stability and you look at what we're trying to achieve, and you know, I can tell you from my days of doing a lot of removables, I was wondering why I had so many kids who had tongue thrust. You know? I'll tell you why, because I encouraged the tongue thrust during the expansion. Now I know that you can trim the acrylic of the plate, but really how accurate is that? And I can tell you the reason I've gone to fixed expanders with minimal stuff in the mouth is because I want to preserve oral volume. Yeah? Secondly, You know how many times I had parents ring me in a mad panic because their kid had taken the Schwartz out at McDonald's, wrapped it in a tissue, and they're going through a dumpster trying to find it? Yeah? How many times have you ever had a kid who comes to your practice and mum says, yeah, my son's wearing his plate really well. You look in the mouth and the plate is 6 millimeters bigger than the kid's mouth. Yeah? And you ask the mum, how the hell is he wearing this? You know, because all mum sees is him sort of put it in front of her when he gets home. So you take mum aside and you say, listen, Mrs. Jones, watch me turn this back 6 millimeters. Now you see it's fitting. Does that tell you something? Now, if she's a decent parent, she'd hit that kid on the head for wasting everyone's time. Yes or no? You know, but, you know, if she's a school teacher and Johnny's the only kid, watch out. She'll say, oh, that's okay, Johnny, we understand. That's a difficult appliance to wear. Wait till Dad gets home, we'll have a family discussion about that. Yeah? Don't have time for that. I spend exactly a minute in my practice per patient. If it goes to a minute and a half, I get upset. You understand? All right? How long do you think it takes me to explain to idiot what idiot's not doing? I fix it in. And I fix it in nowadays without even the parent having to turn the key. Does that kind of make sense? It's because you can have the best treatment plan, the ideal records. What's going to let you down? Patient compliance. And if there's one thing I talk to GPs about who started ortho and then gave it up, it's compliance. You know, I did that and the kid didn't wear the plate and in the end it was just a headache, etc., etc. Right? Can you imagine in dentistry if you cut a crown prep and you give the patient a temporary which they can take in and out? You'd never do that, would you? Because how many patients would not wear it as instructed? Okay, so this is a properly designed Schwartz plate. Why? Because as Dr. Schwartz, who developed this, famous orthodontist from Vienna, he always had 2 screws in his plate. Why? Because from his Schwartz analysis, he would have a distance here and a distance here, and it'd be very rare that distance was the same. His original paper said that in 90% of his cases, this needed to be expanded, not that. Make sense? So if you're doing a Schwartz plate, I recommend you don't, but if you are doing one, you really need to tell your lab technician, I want a 10 mil screw there and a 5 mil screw here. Who says that? No one. I've seen, and Rob shows me the lab forms, he says, Derek, I'm lucky to get a good impression, and the only thing the doctor says is blue sparkles. That's their commitment to design. Yep. And you can see this is an early case of mine where different screws, different expansion. Here is where most of the expansion is really required. So if you are going to do a Schwartz plate, and they do work, then do it properly. Do it as it's designed to be activated. Most of the cases don't need maxillary molar width. They do need here. So if you want to expand here and not there, and you only want to use one screw, you need to put some sort of check. Just like those who did my Damon course, when I'm running class 2 on one side for the canine, but this canine's class 1, we use a delta elastic to lock that in. Here, this is a fan gear, right? So why do I ask you to take a frontal PA skull? Because when I give you a treatment plan that requires expansion or not, I need to be able to tell you how much expansion that kid will need, and I need to be making sure that there is a discrepancy in basal bone. So the frontal, as we saw yesterday, can clearly show me things like nasal problems, but the main thing I use it for is to look at my basal bone width and to look at what we call the intermolar angle, and I'll talk to you more about this when we do the tracing of a frontal. Please make sure you keep in touch with Jane so that she tells me how many hard films to bring versus who's going to be emailed the, the presentation electronically. Course 1 assignment, you're going to get 1 case of ideal records, right? And you're going to have to answer some questions. To answer those questions, you're really going to need to do a Jefferson analysis. So I really want you to have a go at doing it, so when you come to course 2, you're asking the right question. Right? And you can see in this kid's case, after 4 months of expansion, there's now balance between the upper and lower. I'll talk to you about maxillary development, mandibular development, but please don't say stupid things like I'm expanding my mandible, because you will be shot for saying things like that, right? Because there's no suture in the mandible. All you're doing in the mandible is you're uprighting the posterior teeth over the basal bone the way it is. So in actual fact, when we measure the need for maxillary expansion, it's based on what's called the mandibular trough, right? That's where the genetic component comes from. And sometimes, probably in less than 10% of cases, we only need to expand one side. Majority of our cases, the mandible deviates to one side because the maxilla is bilaterally narrow. That's the most common scenario. And I'm going to teach you how to pick that case versus the one that has genuine unilateral crossbite. Genuine unilateral crossbite without a functional shift is normally because the sphenoid is in torsion on that side, right? And we'll learn to look at that very easily on a frontal PA skull. The guy who did all the research on this is a guy called Dwayne Grummings. Dwayne Grummings is an orthodontist in Spokane, Washington State. He came up with his own frontal PA skull analysis. And he again is a good orthodontist because he's one of these guys who believes in expanding when the kid's young so he doesn't have to extract teeth when the kid's older, right? In America, really, more orthodontists do early treatment expansion than those that don't. I think the opposite is the case in your country from what I'm hearing, you know? So I'm hoping that in the future, right, you guys will get out of the dark ages. But I think that all comes down to the education in this country, doesn't it? And I find that in this country, you are a consultant until you leave the hospital in a coffin. Yeah? That's very unhealthy. In all other countries, civilized countries, you can't be in charge of a department for any longer than 4 years. Just like you can't be president for more than 4 years, yeah? Because can you imagine how an authoritative figure who's in a consultant department teaching postgrads for 40 years, is he going to teach new stuff or is he going to teach the stuff that he's been exposed to 40 years ago? This is the problem, yeah? So unfortunately, you can't be harsh with some of your colleagues because they think they're doing the right thing because that's how they're trained to do the thing. But you need to find guys who trained for... Do you have orthodontists in this country who trained overseas, like in the States? Normally you find they will be a lot more progressive type people to deal with. Okay, so how can I expand only on one side? If I'm using a fixed expander, I will ask my lab technician to solder a rigid arm on one side to prevent the expansion. That becomes my anchorage unit. Or if I'm using a removable, I use something like this, which is a Nord expander. And it has a shelf of acrylic doing the same job as that wire would do. But again, when do I do unilateral expansion versus bilateral expansion based on the frontal PA skull? Because remember, when you do your Schwartz-Korkhaus analysis, it tells you the discrepancy, but it doesn't tell you if it's more on one side than the other. Yeah? And we're going to go through that with you. At this stage, you're probably thinking, God, I'm not going to understand all this. All I want you to do is to get good records, analyze them, give me the data. Data in here, treatment plan out there. And by osmosis, by us looking at 60 cases for 12 sessions, 60 by 12, and you visiting the website, you'll get it, yeah? And it'll become like second nature to you, and that's when you start enjoying your orthodontics. Look at this kid, unilateral crossbite, no room for the cuspid, using an expander limited to expansion on that side, correcting the buccal segment. As you expand, you also help class 2 correction because the trapped mandible tends to come forward. And now let's talk about expanders. When I graduated from this country, this was the most common expander. This is called a quad helix. Quad helix is very good for rotating teeth, horrible for expanding. Why? Because the force is on the clinical crown. So as a result, the teeth tend to tip. You understand that? Secondly, if a quad helix is bent correctly, helix 1, 2, 3, and 4 need to be in the same plane. If you make these posterior helices flat, it's going to gouge the tongue. So the technician, can you see here, does what? He bends the posterior helix vertically to make it comfortable, and then that prevents you getting the expansion. You understand? So please, please, I don't want to see these appliances. Okay? These belong with Clark buccal object rule, not Bill Clark, this is Clark who developed the, in that room upstairs. So what I'd like you to do at the coffee break, I want you to go to the museum and I want you just mentally to get rid of all the training you've had thus far. Then I want you to go in the library, born again. Do you understand? Now, this is a quad helix. This is a hyrax. Remember, it could be an RME if you turn that gear twice a day. It could be a slow expander if you turn it just once a week. Older expanders had to have bands on the 4s and 6s. Why don't we do that anymore? If you're doing crown and bridge, you can imagine how hard it is to fit with parallel insertion, a 4-unit bridge. This is the equivalent of a 12-unit bridge. Yeah? There's no need to put bands on your premolars. Because nowadays, the metallurgy of the wire is such that if it's made well, it can be made so that you do get expansion, but with a body wire, not with bands. So when I ask for a banded hyrax, so let's write this term down because through email, I'll be using certain terminology. If you ask my friend Ian, he will explain to you what short class 2 is, long class 2, delta, inverted delta, right? All certain things that mean only one thing and nothing else. So when I ask you, this is a good case for a banded hyrax. I'm talking about bands on your first molars. The most accurate hyraxes are made if you can fit your own bands and then do an alginate over that. But I know you guys won't do that because the inventory costs will be huge because you've got to keep all the different size bands. So the next best thing I would suggest you do is not just take an alginate, send it to the lab and let them guesstimate where to cut for the band. I would like you to put separators between the teeth for a week, get the patient back in, take the separator out so there's a nice 1-2 millimeter gap, take your alginate. Then the technician is not guessing where the band goes. I don't know how many weeks it takes for an expander for you guys, but let's say it's 3 or 4. A week before the expander is due to come back, you get the kid back in, re-separate. Then it's a nice simple transition. The expander fits perfectly. That's a banded expander, banded hyrax, right? I will tell you what rate to expand based on the age of the patient, based on the CVM. If it's a vertical grower, or I want you to use a face mask, I'm going to say, doctor, this is a case for a bonded hyrax. Bonded means acrylic coverage. Totally different animal, and I'll show you one of those in a minute. Okay? So this is a newer style of expander using the body wire to give you expansion. Can you see how the tongue can still be where it needs to go? This screw is an older screw. What's the name of that screw from yesterday? Jack screw, right? Highly unstable. What is the screw I want you to use? Super screw. Trust me on that. I have been using super screws for many years. I measure the changes. It's beautiful, right? Go to the website, superspring.com. Look at all the research by Lewis Clapper. He knows what he's doing. But the point we're saying is when you fit one of these, as you expand, right, the palate wants to come down. But this expander wants to drive into the palate. Does that make sense? So the design I'm going to ask you to do is bands on the molars, but a rest seat on the deciduous molar or the 4, depending on the age of the patient. What does the rest seat do? It prevents your expander from driving into the palate. If you don't put the rest seat, by the time you finish your expansion, 3-4 months, you'll find that the soft tissue is all around these bars. And then it's a real painful experience for the patient. It's a hygiene nightmare, right? Now, your lab should know all this, but of course, I don't know. I don't use the lab you use. Yep. But the lab, Rob's very easy to deal with. But of course, he says to me, Derek, if the doctor doesn't tell me what he wants, I can't think for him. So the expanders, and we are going to get you, in fact, what would be a good exercise, I would suggest at the break, you go and ask Rob to give you some lab forms, right? And we are going to do a little like tracing exercise, you understand? I'm going to draw for you a bonded hyrax and a banded hyrax, the two, and then you keep it somewhere in your notes so that every time, you see that as the diagnosis from myself, from Rita, one of my associates, you know exactly what we're talking about. All right? Now, if I ask for if I see your Short's Corkhouse is normal for the molar, but narrow in the premolar, I will say to you, doctor, you need to expand, but you need an expander only for the premolar region. And I'll ask you to put, this is the only time I don't use a super screw, right? In this situation, I will ask you to use a spider gear. This comes from an Italian company called Leone. And the benefit of this is, as you turn the gear, it only opens up like a V. So you don't get any molar expansion. It's the equivalent of your older Schwartz plate with the fan gear at the back of it. Yeah? So the only exception that I will ask when I ask for, so when I say fixed expander, bonded or banded, I'm talking super screw. Why? Because a super screw is so small, it doesn't affect the tongue. You can put it high up in the palate, and because the higher you go in the palate, the closer your force is to the center of resistance. Module 9, biomechanics. I explained to you why, when you move teeth, you want the force not to be on the clinical crown because it tips. You want it to be near the center of resistance, so you get bodily movement. The center of resistance of molars is the furcation of the molar. So most of your screws, if you just look at the next job you get back, whether it's an acrylic or not, you'll find that the size of the jack screw is such that they can't put it anywhere but on the occlusal. Does that make sense? So you get these nasty imprints of that on the kid's tongue. Yeah. Secondly, you think you're getting that, but really what you're getting is that. All right. So super screw placed as close to the palate as possible. Why are we able to do that? Because during expansion, our rest seats on our premolars and our bands on our molars prevent that from driving upward. You understand? You get bodily movement, the palate is allowed to remodel downward. And we're going to go through all of that with you. Please measure expansion, because if you're using a fixed expander, it becomes difficult if you're using one of these to know how much you really have expanded. You have to get one of these gauges. If you're using a super screw, it's easy, because a super screw has a built-in gauge. As you turn it, a thread appears, and the thread is got gradations of 2 millimeters. So I can look in the mouth in any of my patients and say, right, you're at 4 millimeters expansion, we want 8. So Mrs. Jones, keep turning till you see that fourth line appear. It's so well designed, okay? I want you to visit the Super Screw, Super Spring website. It explains how to fit, how to activate. The rate of activation, remember, for a kid is going to be 1 turn a day, because 1 turn a day with a super screw is slow expansion. I like it because the parents then remember to do something on a daily basis. But to get the initial effect, I like to do a more rapid expansion. So when the expander goes in, I let the kid get used to it. Normally takes 2 or 3 days with speech. Then I will get the parent to give that 2 turns a day, which is 2 swings. 1, 2. And the parent will do that for about 2 weeks. And I warn the parent they're going to see a little gap appear between the teeth. I tell them that's a good thing, don't freak out. Then I give them 1 week of no turning. That's the latency period. And if you read Lazarov's research, that's an important period for those cells that form as part of the callus to regenerate, ready to form the new bone. Yep. Biologically, I want to have osteoblastic activity. Then we do the slow expansion. Once I've finished doing my expansion, right, we leave the expander in normally for 6 weeks, and that allows the bone to remodel. It's perfectly stable. Now, as we get more into it, as you start presenting cases to me, I'll show you how between the slow expansion and stopping expansion, it's a gradual reduction, meaning turn a day goes to a turn every second day, goes to 1 turn a week, goes to nothing. Why is it a gradual? Again, based on the biology. So I'm going to go through that, and I'm going to give you the protocol, right? But at this stage, if you're starting a case and I say it's a banded hyrax in a kid, then I want you to do the parent does 2 swings of the super screw every day for 2 weeks. Then they have a week off. Then you do 1 turn a day, all right? And that 1 turn a day, you're monitoring the amount of expansion. When you get to 70% of expansion, right, and you'll know that from your gauge, then you slow down the expansion. And the reason you're slowing it down, you're wanting more osteoblastic activity, less osteoclastic activity. Yep. There's a chapter from a book by Davidoff, which is called Biology of Tooth Movement. And it's the best explanation of this whole effect, which is called distraction osteogenesis, right? Distraction osteogenesis is not just the appliance you use, it's the method of activation. It's a biological phenomenon. Bill Clark knows all about it because when he designed his new appliances, he has that same slow activation method in mind. This is just kind of showing you typical cases in my practice before phase 3 that have only had, in this case, phase 2. What is phase 2? Orthopedics. What is phase 3? Orthodontics. Who would like to start the orthodontics at this stage versus that stage? This is a bonded hyrax. It has acrylic. Appliance was first designed by Jim McNamara, published in JCO. He talked about reversible face mask therapy and the ideal appliance for that. This is acrylic. And if you do it like this, when you come to remove the appliance, it's going to crack and fracture everywhere. It's very painful to remove. Deciduous teeth come with it, etc., etc. So the proper design of this hyrax, and this is for a vertical grower. Why? Because when you expand with occlusal coverage, you don't want the teeth to tip, because if they tip, 1 millimeter of tipping is going to result in 3 millimeters of an open bite. You can't afford that in a vertical grower. Rate of expansion, just write this in your notes. Rate of expansion for a bonded hyrax in a vertical grower is half of what a normal expansion rate is. So everything I gave you, just halve it. When else do I halve expansion rate? Non-growing individual. So when do I activate a bonded hyrax at the normal rate? When I'm using it purely for face mask therapy in a non-vertical grower. So if I have a class 3A low angle patient, that's a maxillary mid-face deficient class 3, that's before CVM3, I'm trying to get you into the terminology, then I'm going to say, doctor, bonded hyrax, reversible face mask. And the face mask will be a face mask with a chin cut because it's a low angle individual. If I say, doctor, this is a class 3A long, CVM2, the difference is the vertical. And I say, doctor, I want you to use a bonded hyrax with a tandem bow. And I want you to use slow expansion. because it's a vertical grower, you don't want to chink up, blah, blah, blah. So there's a definite reason, rationale in every treatment plan I recommend to you. All you need to do is get me the good oil. Get me the right thing. Now, this is how I'd like you to design your Hyraxes. And I'm not sure, Yasmin, you said that you're getting some dramas taken out. Does your Hyraxes have metal soldered like that before the acrylic? Well, obviously that's the answer to your problems. But if you have a bonded Hyrax that has a metal framework, A, it's easy to remove, yeah, because it doesn't fracture as you take it out. B, when I ask you about face masks, you will get here and here the hook soldered to a framework, okay? And that scaffolding increases the strength, so you get maximum reverse pull. Otherwise, it is the most difficult appliance to remove. And remember, you're normally doing this in mixed dentition. And I always warn my parents. I say, Mr. Jones, I'm warning you now, I'm going to take this appliance out. There's a good chance some baby teeth are going to come out. The reason they're going to come out is because they're ready to come out and they're loose. Now, if you say that, she's happy. Whereas if you pull it out and a couple of teeth come out, she thinks, what the hell is this guy doing? You know. So you give her the good news. The good news is, Mrs. Jones, we're not charging you for these extractions today, right? But if you inform before you perform, that's just so important. Remember, we have just finished the video footage for YouTube on how to cement a bonded Hyrax. There's a special glue we use. It's made by 3M. It's called multi-band cement. It's the only glue you can use for bonded Hyraxes. Why? It's dual cured, so you mix it up, it starts setting, but its final set is once you light cure. Why? You cement it in, all the excess glue comes away, you get a cotton roll and you can just wipe the excess. Because once you light cure, let me tell you, cleaning up is very difficult. This stuff is like concrete. Yeah? What's good about it, it never comes off. What's bad about it is cleanup time, right? What else do I suggest? Never ever etch your teeth, because you'll never get the damn thing off. Yeah? What you do need to etch is this. Your lab should do that for you, but if they don't, before you cement it, you micro etch the acrylic. That gives you better mechanical retention for your multi-band cement. So 3M, just as a rule, are the #1 in anything to do with adhesive technology. I mean, you know that from 3M Unitech is the orthodontic version. 3M, which is a Minnesota mining company, anything, Post-it notes, super glue, all researched by 3M. So if you want my advice, when you're bonding brackets, when you're bonding anything, get the 3M stuff. It's a little bit more expensive, but it's really good quality stuff. So for bonding lingual retainers, I use Transbond LR. Yeah? For putting brackets on, we use Transbond. For bonding Hyraxes, we use multi-band cement. For putting brackets on models, which we're going to cover in course 2, how to do an indirect setup, we use Unitech indirect laboratory adhesive. All Unitech products. Who sells Unitech? I have no clue in your country. In Australia, we buy directly from 3M Unitech. I believe that Henry Schein around the world has a contract with 3M. So if you're a general dentist, you have a Henry Schein account, you'll be able to order everything through Henry Schein. Okay, kids, I use bonded Hyraxes or banded Hyraxes because I think they work really well and they remodel the palate well, etc. Adults don't cope with those appliances. Speech is affected. Adults tend to be the world's biggest sooks. Who would agree with that? So you need lighter forces. So you have two choices. You can use those appliances with lower activation, but no one is going to thank you for that, adult-wise. Or you can learn how to do ALF appliances. Now, please understand, ALF is a philosophy. It's not an appliance. So you can't just tick on your lab form, I want an ALF here. Yeah? What is the different designs of ALF? We're going to go through that. But really, there's 12 basic designs, from a walker for rotation expansion, to an end sagittal for Div 2, to an ALF twin block. You know, we're going to go through all that with you. Write down in your notes, if you email a lab in America, it's called Murdoch Laboratories, M-U-R-D-O-C-H. I get all my ALF appliances made through them. Probably be an expensive deal for you, but at least you can suck their knowledge. So email them. Magic words in any email to any company, use my name first. There's more likely you're going to get something for nothing. Yeah?
Email
Kathy, right? So I will, Yasmin, Jane, they have her email, but if you just Google Murdoch Laboratories, email and say, I'm a student of Dr. Mahoney, we are going to be learning ALF, okay? I'm a novice, could you please send me your CD on the appliances, how to activate them? It's free of charge. What's not free of charge is a video that she sells, which has been put together by Gavin James and Dennis Stroken on how to activate an ALF appliance. But I'm not saying you need that, because we're going to show you how to do that. Yeah? Even though there's no practical component to this course, as the need progresses, I will probably do some activation on the video, right? So at some stage, Yasmin, can you please just sort of remind me to bring with me an ALF appliance, pliers, you know, all that sort of business. So, and then what we could do is I will do it here. You'll bring your camera so that it can be maybe blown up there or something like that, right? But as I said to you, that the way I'm in charge of your theoretical didactic learning, yep, references, what to do, how to diagnose. Rita really should be in charge of your clinical experience. Does that kind of make sense to people, right? She's the one that will hold your hand through the stage by stage, what to do, what is a 14, I noticed Derek's recommending starting this case with a 1425 copper night tie wire. Where do I get that? She will help you with all those sorts of questions. Yeah. So please understand, to get the most out of this course, your homework is to get some good cases going. Yep. You can wait till course 2 and show me those cases. More than happy. I'm hoping all of you bring 2 cases for diagnosis, and you'll learn 60 cases next course. If you don't want to wait that long and you want to start earlier, then by all means, get Yasmin to show you how to do a compressed PowerPoint, email it to me, and remember, it's a second opinion. So you need to fill out the column that says diagnosis, treatment plan. It'll prompt you, if you use the format she sends you, phase 1, phase 2, phase 3. Forces you to say, is there a tongue thrust? Is it? And we're going to go through that today. I believe some doctors are showing me cases, so you get an idea of what I expect. All right? Now, ALF appliance. ALF appliance is made of a special alloy called L-Gilloy. And this L-Gilloy, even though it's light, once it's been soldered correctly and reflamed, it becomes very springy. So whoever makes your ALF needs to make sure they laser weld as opposed to solder, right? If you solder, the heating of the L-Gilloy causes it to lose its spring. So if you get a job back and you see big lumps of solder here with little pits, send it back, because that's ridiculous, right? Your lab should be laser welding, and you need to sort of take charge of this. You know, I guess, you know, I feel sorry for you in that you're new, but at the same time, you can't just be hoodwinked by the lab fobbing off whatever else, you know, he did on the day. You need to drive the situation. I'm sure you know, if you do crown and bridge work, when to send back a crown, yes or no, right? Well, in the same way, you need to not let the lab sort of, the best customer for a lab, an orthodontic lab, is a dentist who knows nothing. Who would agree? Yeah? Sound familiar? Well, you are now going to be empowered with knowledge, and you're going to say, I want this, and if I don't want that, I'm going to go somewhere who does do it. And once you've got a good job back, then you keep maintaining that standard. All right, so I'll help you with your designs. ALF designs we're going to cover in the ortho-perio, because that's an adult module. Yep. But before that, I want you just to realize that if I have an adult that has a narrowness greater than 5 millimeters or a high palate, like an airway thing, I use an ALF before I use Damon. All right? If it's less than 5 millimeters, Damon is all I need, or passive self-ligation. The other appliance I use for adults is this one. Why? Because again, it's very light. Benefit of this versus an ALF, 1/10 of the lab fee. No need for you to activate. It's pre-activated, preloaded. This is called an NPE2. Same force as an ALF, same philosophy as distraction. This wire is made of titanium, but what's called thermally activated titanium, which means that when you freeze it, right, or in your country, leave it outside for a minute, it undergoes martensitic transformation and it becomes like spaghetti. So it's easy to fit. Once it reaches body temperature, then it will start unraveling and giving you the expansion. Yeah? So the company who makes this and sells this is called Ortho Organisers. Again, find out who your rep is in this country. There are 7 clinical articles on its usage by orthodontists. How to fit it, how to activate it, so all that info you can get. I'm going to just run you through the basic use of it because, again, I'm just introducing it as an appliance because when I email you back, I will say this is a great case for an NPE2. Why do I use NPE2 versus ALF versus Hyrax? NPE2 is the only expander I'm going to recommend to you that gives you rotation and expansion without you having to do any activation. Bottom line. ALF will give you rotation, but you need to be able to activate and design the correct loop for rotation. So it's a little bit more skill level. Why do we need to rotate? Please understand, when you have a narrow jaw, no room for the teeth, expansion will certainly give you transverse improvement. But expanders don't rotate your molars. Do you understand? And normally you should rotate your molar before you expand. Right, so in order of priority, for those who've done skip through courses, I'm pretty sure he still talks about arch development checklist, division before transverse. So if you use a 3-way, you normally use the posterior acrylic for anchorage, and right. He normally would say if you have a dental crossbite, it should be eliminated before you do your skeletal. Yes or no? Similar principles. These are orthopedic principles which have been around for hundreds of years in Europe. Okay. So, NPE2, benefit, you can combine it with braces. You don't have to buy the entire kit. Again, as a general dentist doing limited work, it's not going to be in your interest to have a huge inventory. So what you can do is you can order the size you need. How do you know the size you need? It's your Schwartz Korkhaus Revisited. You measure the width of the 4 incisors. That will tell you what the ideal width should be for your case. You subtract the ideal width from the current situation. And remember, the mandible is always going to be your guide because you can't expand the mandible. And then the discrepancy, here it's very minor. So really, it's unrealistic. It's a teaching situation. But if I have a 4 millimeter discrepancy, I'm going to do it with braces. These are older slides before passive self-ligation, where you wouldn't get 5 millimeters of expansion just using a twin bracket. Nowadays, if I have a rotated molar and less than 5 millimeters of expansion, I will put my molar tube more mesial on the molar I will go into a light 014 copper nitrile wire. It will derotate my molar as it starts my expansion. And I will get the expansion I need without an appliance. These are older slides and you'll see they're using either delta force brackets or twin brackets. With those systems, you're not going to get the expansion. That's why you have two choices in life. You can upgrade to passive self-ligation, or you can stay with twin, but it just means you're going to be doing a lot more orthopedic development prior to your bracketing. That's totally up to you. So again, this distance was 34. You add the 4 millimeters expansion you require, so you can now tell your supplier, please send me a 38 millimeter NPE2. To fit that, it doesn't come with the bands attached because obviously there's different size molars for the case. So what it comes back as is just this little bit here, and it has these sheaths which go into the thing. Now you have two choices. You could ask your lab to solder the NPE2 to the molar bands if they're the ones who are making your molar bands. And that's what I suggest you guys do. In my practice, we have an inventory of molar bands. We have the whole kit of NPE2. So if I need to do it, I'll reach in my drawer, take out size 38. I will fit my molar bands with lingual sheaths, and then I will tie the lingual sheath off the appliance, that's how it comes out of the packet, into my molar band. So again, it depends on what you want to do. To activate it, it's activated outside the mouth. You can use endo ice, chill spray. To fit your bands, you can get a lab to do it, which you guys would normally do because you don't want to keep the inventory. Then I would suggest then don't get the lab to do a lingual sheath. Get them just to solder the appliance to the thing. Then you have no chance of things coming out or emergencies. What I do, I select the right band. I then engage into a lingual sheath on that molar band, my expander, and I metal tie with 012 ligature wire just so that there's no emergencies. Once I've got those on, I will then put gauze around this part, the middle part, wet the gauze and put the thing overnight in the freezer. The freezer with the wet gauze will then cause this to be like spaghetti. So when I fit it, it's really easy because it's not trying to expand as I shove it in the mouth. Does that make sense to people? Right? So I then use my 3M multi-band cement, same one I use to cement my Hyrax. We light cure it. What's good about this appliance, when you cement it, if your molars are rotated, the expansion arms will not start working until your molar de-rotates. So it's a very clever design. So this thing is your molar rotator, your expander, your retainer for expansion as you do your initial fixed. It's a good appliance for thumb suckers. If you don't want to have a lab fee, most thumb suckers, and we go through thumb sucking in detail in mixed dentition module, how to stop it, when to determine if you need to expand, etc. But most thumb suckers will have a high palate and will have molars that are rotated. If you listen to Skip, he's absolutely correct. If you look at the upper model of a kid who sucked their thumb and you put that model on the table, it will rock where? On the mesolingual cusp of the upper first molar. Have you heard him say that? Absolutely. Why? Because this causes the molar to tip and rotate. Yep. So this is great for thumb suckers because it actually derotates the molar for you before it expands. And of course the kid can't get the thumb in there because when you get this thing, you can bend this to prevent the thumb going in. But bottom line is, with thumb suckers, you've got to break the habit. If you don't break the habit, all your orthodontics is a waste of time. We all agree with that, don't we? Yet, when I talk about mouth breathers, your guys are happy to start the orthodontics without fixing the mouth breathing. Do you understand what I'm saying? Phase 1 is so important to me because it's the root of all evil. It's the etiology of the malocclusion. If you can eliminate the causative agent, you will then, have that